Good evening, everybody, and thank you for joining us this evening. Tonight, we've got a fantastic case-based presentation on caring for women with complex needs during pregnancy. I'm Sandy Vincent from the PHN Education team, and I would like to start by acknowledging the traditional custodians of the lands that we all live and work on. I'm in Dalkinjung land down on the Central Coast, and I'd like to pay respects to elders past, present, and emerging. As I said, we've got a fantastic panel assembled tonight. Dr. Andy Woods is the medical lead for Women's Health and Maternity Network at the Hunter New England LHD. Dr. Jyoti Chaku is a staff specialist obstetrician at Tamworth and Armidale Hospital. Dr. Blake Knapman, obstetrician, gynecologist, and laparoscopic surgeon at Tamworth Hospital. Dr. Cheryl McIntyre, GP obstetrician, Inverell Medical Centre. Facilitated by Professor Michelle Guppy, who's the head of the School of Rural Medicine, the University of New England, and Sandra Fitzgerald, who is our lead clinical editor for our PHN Health Pathways program. Just a couple of things to let you know about this session tonight. We are recording the session. And if you have any questions during the session in the interim, if you wouldn't mind just popping those into the chat, we will be monitoring those. Or if you want to join in the discussion, you can unmute your microphones at any time. There will be an evaluation at the end. I'll put a link to that in the chat as well. We really value your feedback, so please do participate in that. And with that, let me hand over to Sandra, if you wouldn't mind opening your slide deck. Thank you. That looks fantastic. We can see the slides.
Excellent. I will turn my camera and mic off now and hand to Cheryl. Thank you, Cheryl.
Okay, so we just wanted to present a case to you all this evening to have a look at the pathway that a particular lady took from her rural home in Inverell, New South Wales, to birthing in John Hunter Hospital, and to sort of flesh out some of the challenges in antenatal care and shared care, and highlight ways that we can better communicate and connect with each other to try and improve patient journeys through their care. Next slide. So our lady in this case came in quite early to see me to confirm an IVF pregnancy, to make sure Bub was in utero, and to see the heartbeat. She'd been having some specialist care away in Toowoomba and was going to be returning later on in the first trimester for further care. Wasn't certain where she was going to birth at this stage. So as you can see, observations are all normal. She's got further appointments with her specialist, so she came back in at 9 weeks. Was well besides quite intense nausea, for which she had some Maxilon and ondansetron. Had a little bit of back pain, but no PV loss. Bowels and bladder were normal, and Bubby's heartbeat and fetal movements were seen on a bedside ultrasound. So as things progressed, we met up again at 14 weeks. Everything was going well. Nausea had settled. So we did a longer, more comprehensive visit to assess all of her risk factors through the pregnancy. And she decided that she would like to birth in Inverell. So we went through all of the details. She'd finished her pessaries from the IVF, and we went through all her risk factors. During her workup for IVF, it was discovered that she carried the SMA gene, but her partner didn't. So we didn't need to do any further work on that. And we were going to repeat all of her bloods because most of them were now 12 months old while she'd been having the IVF. She did have a past history of not PCOS, but insulin resistance. So there was a plan to do an early GTT in her pregnancy. On the ultrasound on that day, the baby was very active. She had no other risk factors besides the IVF pregnancy and being Asian, Southeast Asian, and also the insulin resistance. Next slide, please. Thank you. So some bloods were done shortly after that visit, which showed that she was also mildly hypothyroid. Her early GTT was normal, and also the HbA1c was normal. So we met up together and started her on some thyroxine with a plan to repeat that in a month to 6 weeks to make sure that that was correcting. The findings on that visit were also normal. Not feeling any movements yet, but a very active baby on ultrasound by the bedside. She was given a form for her morphology scan and was found to be non-immune to varicella, despite having had 2 vaccines in the past. So she had a morphology scan done, and all the findings were normal. Bub was lying on the 47th centile, which was good. Only thing of note really was the placenta was quite low lying, so it was actually abutting the os, but not actually covering the os. Other than that, the ultrasound was all normal. So her next visit at 22 weeks, she definitely decided she wanted to birth in Inverell. So she was referred to Inverell Maternity for birthing. She remained on her low-dose aspirin, which had been started because of the 2 risk factors mentioned earlier, and she was given a form to repeat her thyroid function. She seemed to have some silent reflux with a little bit of unusual sort of something stuck in the throat feeling and a bit of coughing at night time, and she was going to trial some Gaviscon for that. We also plan to do regular growth scans just in view of the fact of those 2 factors for her fetal growth restriction risk. Next scan, please. So by the time we got to 24 weeks, we did the second glucose tolerance test, and she was found to have gestational diabetes, with those 2 readings being elevated. Again, all her findings on examination were normal. Baby's heart rate was good at 146. The thyroid dose was good with a normal TSH now. The baby seemed to be growing appropriately. So the main thing that we were focusing on was the gestational diabetes and monitoring sugars. So I referred her to the diabetes educator and the dietitian for lifestyle interventions, and to begin blood glucose monitoring. The plan was to continue reviewing her monthly, but to do weekly BGL emails so that we could track how her sugars were going and whether she needed anything else for that in between visits. She was also aware that she might need to birth in a bigger centre if she did need insulin through the pregnancy. Thank you. So her next growth scan, 30 weeks, was good. Bub's growth was on track, but unfortunately her placenta now was a grade 3 placenta previa, so it was actually covering the os. And so the plan to birth in a low risk centre was not going to be possible. And so I, in the next slide, please, plan to link her up with the virtual high-risk clinic, because I thought that she may not be able to birth in Armidale or Tamworth with that scan result. So I wanted her to link up with John Hunter, and it's a long way to drive down there for antenatal visits, so I was trying to help save her some travel. But everything was progressing well besides that. She was aware that not to allow anyone to do internal exams, no intercourse, but it was okay to do a transvaginal scan at a later date to check and see if the placenta had moved further away from the cervix. She was updated with her vaccinations, so she had her Adacel and RSV vaccination, and the family were also organised to have all of their Boostrix vaccinations. She was started on some metformin because her BGLs were mildly elevated, and we were just starting off with one of the 500 milligram metformin with a plan to review later on that week, and email her BGLs in. So if they weren't improving, then we could increase from there. So by 32 weeks, again, all her findings on examination were normal. Some of her fasting sugars, however, were above 5.1, and also she had some postprandial readings of up to 8.4. So I increased her metformin to 1 gram with a plan to review in 1 week and start insulin if it wasn't brought under control within a week. We hadn't heard back from the virtual high-risk clinic just yet, and she was also planned to have another growth scan in 10 days' time. So again, we met at 33 weeks. All of her examination findings were normal, but I was concerned because we hadn't heard back from the high-risk clinic at this point, and we were getting closer to term. So I rang and left a message at the virtual high-risk clinic and was awaiting a call back. The person that called back wasn't familiar with the type of referral that I'd sent through the Sent referral system, and they were going to escalate to Pregnancy Care Connect to find out what steps to take next. Her sugars were still mildly elevated, between 6.2 to 8.9, but the fasting readings were good. So at that stage, I continued on the metformin, but planned to add in some fast-acting insulin with dinner because that was the one that had elevated sugars. And she also was reconnected with Community Health, with the diabetes educator, to do some more education around use of insulin, how to give injections, monitoring, and what to watch out for whilst on insulin. She also had a constant low backache, but didn't seem to be contracting, had no PV loss, and really good fetal movements. And I thought it was just pregnancy-related back pain that wasn't to do with any contractions. And we booked another follow-up growth scan to again check and see where the placenta was and to make sure Bub's growth was appropriate. Her scan at 34 weeks. Bub's growth was appropriate. The estimated fetal weight was still on 51st centile, which I was very happy with. The placenta, thankfully, was now anterior, low-lying, but about 9 millimetres from the internal os, so no longer covering the os. All the other parameters were normal. So I was still concerned that she still needed to birth in a bigger centre, given the fact that she had an anterior placenta and still a low-lying placenta. So now we're up to 34 weeks. Again, clinically, she was doing very well. Weight gain was appropriate, blood pressures and everything remained stable. The baby was cephalic. We knew about the low-lying placenta. Her sugars were still mildly elevated, particularly postprandial, and so I was increasing her insulin. So she had 2 units at lunch and then 4 units with dinner, and the metformin in the background. Her aspirin was planned to continue until 36 weeks, and she was going to have another growth and placenta scan at 38 weeks also, and she was planned to see the virtual high-risk clinic a few days after that visit. So we had some more discussion between the LHD regarding the place of her birth. So it was planned that we discussed it at the Armidale Hospital MDT meeting. She'd seen the virtual high-risk clinic by that stage, and the plan was now for Armidale. But there were some concerns because it wasn't known which would be in attendance at the time that she came in, and there wasn't sort of a backup plan for that. So it was thought that probably a higher level service such as Tamworth or John Hunter was going to be appropriate, unless the placenta had moved further away from the os by that stage. So now we're at 36 weeks. Her observations were all normal. Fetal growth appeared appropriate clinically. She was referred to John Hunter, and they booked her in for a caesarean birth on the 16th, so in 2 weeks' time. And she developed itchy hands and feet. So I requested some bloods for bile acids and LFTs, concern obviously for cholestasis. She also had her other iron and other routine pathology done, and a group B strep swab done just in case of rupture of membranes prior to the Caesar. Her blood sugars still remained elevated, so some of her fasting levels were now elevated above 5, and also 2 hours post-dinner was elevated. She was given a script for Protophane, I think from Armidale, but she didn't actually have any instructions on the script. It just said Protophane. It didn't have any instructions as to what to do with the Protophane or how much to take or when for her to use it. So we tried to map out a plan of when to take that, and she was aware to present obviously to maternity if any other concerns were happening between now and her time of travel to John Hunter in a week's time. At her 37-week visit, again, clinically, everything was going really well. Blood pressures were stable, urine was clear, cephalic baby, nice active baby with good fetal movements. She was still awaiting the bile salt result, and some of the LFTs had come back, so her transaminases were mildly elevated. Other than that, her bloods were normal, and I was going to plan to contact her again if she needed any more management before her John Hunter antenatal clinic visit on the 10th in 3 days' time. And I increased her insulin according to her BPs. So at that stage, all I had was the ALT, AST, the bile acids hadn't come back. I think it came back the day after that visit, and it showed just a mild cholestasis of pregnancy. So I next got to see her after her Caesar, which had gone quite well. She was very happy. Clinically, she was well. The bleeding seemed to be settling down. The C-section wound was looking really good. She was still on thyroxine and Ferrograd, and she told me that the metformin and insulin had been ceased after the birth. Bowels and bladder were going well. She was breastfeeding and no concerns with that. We made a plan to recheck her thyroid and recheck her glucose tolerance to make sure that the gestational diabetes had resolved, and also just to check her iron and her full blood count. The baby's sugars were good after the birth. Baby's weight was 3.2 kilos, and had a midwife home visit, which showed Bub to be 2.9 kilos at the 5-day check, which is reasonable, so less than 10% loss. The baby was a little bit unsettled in the mornings, a little bit vomity. She was breastfeeding and topping the baby up. And so we made a plan just to make sure she was burping the baby during feeds to try and reduce the vomiting, given a Fluvax, but Bub was weeing and pooing well. So just to summarise some of the things that were happening throughout her antenatal shared care pathway, she was referred into the local maternity early on in the pregnancy. She also was referred to community health for diabetes educator and dietitian. She was referred to the virtual high-risk clinic. She was then referred to Armidale Hospital, who then asked me to refer her back to John Hunter again. And then she had a nice elective caesarean, which was fairly uncomplicated at 38 plus weeks down in John Hunter. So that's a summary of the referral processes that occurred. And I guess it's open now to have a discussion about choices of where we refer people to, and also how we can sort of help smooth out the referral processes to make that a little bit easier. Hand it over to you.
Thanks for the presentation, Cheryl. And I guess the key features on that case were that initially it was an IVF baby, so had been already receiving some care outside of the region. And it sounds like things were pretty much chugging along quite nicely until a couple of things started to happen with the low-lying placenta on the morphology scan, and then the gestational diabetes diagnosis. So I guess this is a woman who's got two complicating factors. I notice on the line that we've got a couple of GP obstetricians, but we've also got a few people who are GPs who are probably seeing some antenatal ladies as well. So I guess my first question for the panel would be, the first thing that came up was around the low-lying placenta. Let's just pull those two things apart. Let's just talk about that. That was picked up on the morphology scan. I guess at what point are you wanting a patient to be referred into either the GP obstetric services or into the local hospital, be that Tamworth or Armidale in the region? So that's probably my first question for obstetricians in the room.
So actually, is that okay if I take that one, only because I just recently sent out something to all the GPs in the Armidale region anyway. So actually, as per our sort of community health pathways, it is actually recommended that we do receive referrals for women by 14 weeks. And now the critical reason, sorry, I am stepping a little bit away from this case, but the critical reasoning there is that we need to be ensuring that women have adequate preventative measures put in place. And that is getting more and more complicated with the amount of sort of screening that we can do, particularly at the 12-week scan. And also that we are moving towards a system that will ensure that women are seen within the public system for around that 12-week scan. It's not obviously happening just yet in our area, but it is coming. And that will be a significant change, and I'd like to see us sort of moving in that direction. So that's probably the first point that I just wanted to get across, that is something that we're really trying to encourage, is to make sure that those referrals are done. We are still happy to have women cared for in the community by GPs. Thank you for putting that up. But if we can be a part of that process that ensures they're getting that preventative care, that I think is what's critical. And whether that be our GP obstetricians or through the antenatal clinic, I think that's what the key is there. In terms of the placenta previa, I think Cheryl did the right things in terms of the referral timing for that, because obviously we would like to repeat the ultrasound after the 20 weeks into the third trimester, because if it's moved and it's out of the way, then it's obviously not an issue, as long as the woman hasn't had any bleeding. I'll let the others have a word.
Andrew or Blake, would you like to comment at all?
I think Jodie covered it for me, really. Thank you, Jodie, for that piece, particularly to do with the low-lying placenta at 20 weeks.
I agree. I suppose my only question is, for low-lying placenta, why it was considered inappropriate to birth in Armidale.
So I think at the stage that I referred her to the virtual high-risk clinic, it was because it was a grade 3 placenta previa, so it was actually covering the os. And so not knowing which way things were going to go, whether the placenta was going to move or whether it was going to become more of a problem, I wanted to make sure that she was linked in with a higher level service.
Oh, yeah, look, I completely agree with your decision-making, Dr. McIntyre. I just more mean, when it was reviewed later on, unless I misunderstood, it sounded like at an MDT with the knowledge of the new placental location. I must admit, I find the story of the placenta a little bit unusual, in that it was low and then it was covering and then it was back. Anyway, that's fine. But for that to then still be sent away from Armidale, I certainly thought that would be within the delineation of Armidale. Am I wrong?
Yep, It probably should be.
No, Blake, you're
mm.
correct. If you look at the service capability per se, I think we need to acknowledge the workforce fragility in some of our services, which may change that. But yes, certainly a minor placenta previa, and as you say, that changed through the course of the pregnancy with the appearances on scan, should be within and is within the service capability of level 4 services such as Armidale and Tamworth.
Cheryl, did this case actually come to our MDT meeting?
Yes.
Because I don't. Oh, I did. I don't remember it at all. But I certainly wouldn't have been encouraging that. But then the problem is that it is essentially a locum run service in Armidale at the moment, apart from myself. But I'm not actually doing any of the deliveries at the moment. So I'm really just running the clinic. And obviously helping with our MDT meeting, which is where we're trying to make sure that we do speak about these women from the region that are more complex and ensure they have appropriate birth planning. So I can only comment on the fact that we it is a very fragile service in Armidale at the moment in terms of the locum run cover, and it depends who's around. And the other thing to be aware of is that there at times it literally is only that obstetrician in town. Yes. There is no other person there. We only have one other GP obstetrician that's doing deliveries at this point in time, and he's often not there. So there is no one to call for assistance. And as we know, even with a minor previa, you can still get significant bleeding. And I think that was possibly the concern.
Yep. I think that was the thought process that, there's, one person there, and we didn't even know at that stage which clinician it might be at the time that she was going to need to birth.
So the other main issue for this lady was gestational diabetes, which wasn't picked up on her earlier GTT, but was picked up on the GTT at 24 weeks. So I guess it'd be great if we could have a conversation here around what are the supports for gestational diabetes, supports for GPs, supports for the GP obstetricians in the region, and I guess at what point do you tend to escalate care? Open that question to anyone.
Well, we do have the diabetes educators available in most of our larger centres. So, Cheryl, I do believe we have the diabetes educator there as well. Certainly in Armidale, Tamworth, Gunnedah, I think even in Glen Innes, we've got diabetes educators available, and they have a wonderful resource, and I certainly refer all women through them, and they usually have their link with the dietitians as well, to ensure these women are sort of getting a rounded aspect of their care. So I'm certainly, I think we should obviously be referring through them. They certainly do manage most of the stuff. Unfortunately, we are a little bit limited about the endocrinology cover that we have. In all areas, even in Tamworth for obstetrics, I think still Blake. Well, I'm not even sure we have a regular person there at the moment in terms of an endocrinologist, but we still always have access to our endocrinology team through John Hunter if there's more complex cases. And there's also in Tamworth a CNS diabetes nurse who is very skilled in the management of more complex cases as well, who's always available for discussion, Kate Ryan. And then obviously, as obstetricians who manage this very regularly, we're always happy to, I'm speaking for you as well, Blake, here, but I mean, I'm certainly happy to manage the more, simple cases of diabetes in pregnancy to a certain degree as well, because it's something that we've covered many times in the past, and I think we're fairly confident with that management.
Sorry, can I just jump in here for a minute and just put a little plug in for people like Katie Wynn and Alison Gabor, and I'm sure Andy's eyes will be on this soon, but as you all know, the Australian Diabetes in Pregnancy Society guidelines were updated in June 25. So the gestational diabetes pathway is about to go live. We're just in the final stages of signing that off. So stay posted.
It's waiting for its final approval for District Quality Use of Medicines Committee. And yes, I'd just like to acknowledge there's a lot of expertise in obstetrics, GP obstetrics, general practice in the management of diabetes in pregnancy. We do have endocrine support, although it is, at times difficult with leave, etc. But I do know that the diabetes network within Hunter New England is looking at providing support for our more rural and regional sites to ensure that when there is period of leave or gaps in endocrine support, acknowledging the importance of educators and dietitians too, that we do fill that gap. So there are pathways for the more complex and for clinicians to reach out for support. And I can follow that up with the network just to see where that's at, unless Jyoti has any update for Armidale or Tamworth. No.
Certainly also for anyone that's delivering patients privately, there are a lot of that can be managed via telehealth. So if we're having, certainly for my complex private patients that I'm having difficulty getting endocrine support, there's a person I use in Sydney who's an obstetric medicine physician and endocrinologist who provides wonderful service at a fee, obviously, because it's private. But if anyone is doing private work, those are still options and will give excellent care.
So I'm not at all familiar with the virtual high risk clinic, and it would be great if we could have a conversation about that and just explain to the GPs on the line who may not be familiar with it what it is and how it works.
Michelle, I think the easiest way, Sandra and I here goes Sandra. We walked through the pathway this evening. And it's a district-wide program, born out of Pregnancy Connect. And I won't just read out the pathway, but really it's designed to firstly connect women in priority populations who are struggling to access or have not accessed care. And for the high-risk clinic, particularly women who are struggling to travel to our regional centres or John Hunter to provide some virtual specialist support. And my understanding, as I do a lot of this, is we can connect women with their services, talk about birth planning. So without knowing the specific case, Cheryl, I think there were opportunities here for the woman's journey to be different and smoother. And I might take an opportunity offline to understand a little bit more about the woman's details, to be able to look at that to see if we can prevent the challenges you faced, and of course the woman faced, happening again. And ideally, this is not around taking over care, it's about linking women with care. And I do spend quite a bit of time, talking to Blake and Jyoti about women who may be referred through to me that would be very well managed, easily managed, either virtually through Tamworth and Armidale, or with support travel for face-to-face antenatal care and also birthing. Thanks.
Mm-hmm.
And so who can refer patients to the virtual high risk?
Anybody.
Mm-hmm.
And we'll even accept self-referrals from women who are struggling to access GPs, GP obstetricians. Very happy if women are struggling to access care to see them without referral. And
Sandra, you did have the referral criteria up there. It was actually quite helpful to
I'll pop it back up again. Yes.
Yeah.
Did you want to see that?
Just the referral criteria there, so that it was women less than 20 weeks. Just to scroll down a bit or scroll up a little bit. Greater than 28 weeks who've not engaged in any antenatal care, and then women who are less than 28 weeks who are having some barriers to accessing care.
Michelle, we also have 2 Pregnancy Connect care coordinators, midwifery managers for the southern part and the northern part of the district, who are very active in this space. They've done a lot of work to socialise the Pregnancy Connect principles and philosophies, and have done a lot of work with the service providers that may see women in vulnerable situations, sexual health, drug and alcohol, EDs, and as you see, DCJ, as well as SUPs. So they've done a lot of work, and if anyone online is interested, they can reach out to me. I know Michelle Foster's online, the WAM midwifery manager. Very happy to provide anybody online with further information about Pregnancy Connect, and how you might be able to connect with Pregnancy Connect to support the women you may provide care for. Thanks.
Great, thank you. Blake or Jyoti, did you have anything else to add about that?
Yeah, no, it's a great service to be able to have, but just to also know that for the GPs that may listen to this later or are online now, you know, that certainly for Armidale and Tamworth, I'm available by phone, you know, or email. If there's any questions or difficult patients that you have that you are not sure about or are struggling to get to appointments, we work very, very hard to keep our women in the region so that they're not having to travel to John Hunter. So Blake and I run the high-risk clinic in through Tamworth. I run the clinic in Armidale. You know, and we've been working very, very hard to, you know, keep women locally where we can, obviously safely. And there's many, many women who, even when we do refer them, they struggle to travel, and we will still continue to look after their pregnancies. So yeah, what I guess I'm saying is reach out to us as well. You know, we're available for, you know, information if you need it.
Yeah, absolutely would like to echo that. I think Jyoti and I really share a passion here in keeping our women local wherever possible. I'm very happy to be contacted about any patient at any time. That's fine.
If anyone in the meeting wants to post a question, please feel free to either type something into the chat or just unmute your microphone and jump into the conversation. Happy to take questions either way.
Michelle, it's Andy. Sorry to interrupt
Andy.
you. Just to reiterate, there's 3 open doors here online tonight. Blake's, Jodi's, and myself, and we're all, you know, we all communicate, ensure, you know, women are seen at in the right place at the right time. And yes, we're all committed to keeping women within the region. So, you know, reach out to any one of us, and we all talk, chat, you know, support the pathway of women. And as I said, you know, we connect women with care in the right place. So thanks.
Yeah, no, it's great to have the 3 of you here having this conversation. So while we're waiting for... Yeah,
sorry, just as a little extra. So, I mean, as a GP, obviously, we want to try and connect people into care in the most appropriate place. So it's great having that feedback as well from you to know where we can connect people in, and trying to connect them up with the correct service as early as possible, and not having to sort of get them to jump around between services. Obviously, things evolve for this lady, and so the extent of all of her complexities weren't there initially, and so it's understandable that the plan had to change as things evolved, but that's really good to know other options. And one of the other things that I think the high-risk clinic, the virtual high-risk clinic, had only just started operating at that stage, so we weren't quite sure how that sat in amongst everything else. And I think it's a great way of linking people with care so that they don't have to travel 6 hours down and 6 hours back if they do need to link up with John Hunter level of service. But also, it'd be good to have some way in the system that we could then send the referral on to the next person without having to refer, re-refer and re-refer, because I had to write so many different new referrals. And I believe there is some way within the sent referral system that referrals can then be forwarded on to the next service if it's decided that, no, this isn't the right level, we need to send them to another level of service. So that'd be good to have a look at that as well, and just see, can we sort of expedite or smooth out the referral when it needs to then be reallocated to a different service.
I think that's an Ian O'Day question. Sandra, is that
Yes.
something for Ian?
Yes, that is definitely an Ian O'Day question, and we will take that on notice, and I will forward that straight to him.
Yeah,
Michelle,
certainly a system question, Cheryl. Sorry, Sandra.
Yes. I just, while there's just a break in the questions, not that they're coming thick and fast, people. You've got the brains of the universe here if you've got anything you want to ask. I just thought this particular team are very engaged with both the community and the hospital health pathways for maternity. So just wanted to remind people that if you're looking for information, you can pop onto Health Pathways, and the ones that I've highlighted are the ones that are currently under review. And about to or have already been under Andy's nose because of changes in guidelines and so forth. So those ones should be going live in the next month or so. Particularly want to draw attention to the perinatal mental health one, because that one has had a complete rewrite. With Ria Leonard, who's a perinatal psychiatrist, and the referral page has had a massive rewrite, which we're hoping will now be a lot more user-friendly for GPs to use. So we've got all the kind of acute referrals at the top of the page, and then we've divided up the services according to what the pregnant person and their families, partners might need, depending on where they're at. So just wanted to draw attention to that.
I've got one more question. If we don't have any more questions online, we might make it the last. And this is particularly for Jyoti and Blake, what is the current and future status of GP shared antenatal care at Armidale and Tamworth?
That's a very good question. It's a loose arrangement at the moment, unfortunately. And what I would like to see happen across both, our whole region really, is that we do have some form of credentialing for our GP obstetricians who are going to continue to participate in antenatal care, because I think it is an essential component, essential, pathway that should be offered to women. But at the moment, we don't have anything like that. And generally that would need to have some obstetric oversight as well, to have someone available for, consultation and questions like we do with our MGP teams, etc. That's midwifery group practice teams, which has been a bit of a challenge for us in the past because of staffing levels. But yes, I think we are definitely going to have to look at that. Yeah. Thoughts, Blake?
Yeah, Blake?
No, look, I completely agree. I think that the problem is going to be the problem has been, at least since I've been here, which is only a very short time, and I'm very aware of that, is that our staffing issues have been such that it was just probably a bit too big a problem to tackle. It certainly, I think, is an excellent model of care, and it provides continuity for women, which is very important. And ultimately, at a time where our staffing levels, particularly from a midwifery perspective, are occasionally compromised, having a degree of antenatal care in the community, is helpful to us. I mean, I can't see any boundary to it. It just has been us finding a way to kind of make that happen. But perhaps Jyoti and I can talk about that again. But no one is opposed to it, certainly, and I think it would be a good thing. But it needs to be done in a structured way.
Yeah, so certainly I moved to Armidale from Queensland and was regularly doing shared antenatal care with the Brisbane hospitals, having done some additional obstetric training as part of my GP training, but was not a GP obstetrician. What sort of a skill set or training do you think non-GP obstetrician GPs, so just regular GPs, what sort of skill set or CPD would you like to see those GPs do or have done to be comfortable with a shared antenatal care model? Or is that a big question for
That's a big question for a young player like me. I don't know if Jyoti's got anything to add. I'm just going to use youth to get out of that. Not that I'm young, I can assure you. But I suppose the women's had quite a good model. I always refer back to them because it's all I know. They had quite a good model, and I feel like the way they ran it was there was an oversight. And I don't know if John Hunter do this. I genuinely don't know if there's a GP share model care down there, Dr. Woods. But certainly the women's, the way they had it was there was an overseeing obstetrician. There were clinics that were specifically GP share care clinics, which we don't need or would be able to establish here. And it meant that there were certain time points in the pregnancy that they were seen in the hospital. But otherwise it was managed in the community, and that was kind of good in that it meant that if there was an issue, there was an immediate referral pathway, so that they just ring up and make an appointment, for their next scheduled appointment if there was something that propped up. And sometimes they then stayed in that clinic, which was sometimes a problem with junior registrars that didn't want to make decisions, or they would be appropriately dealt with and sent back to the GP where they continued care. And I feel that model works really well. I do think having some hospital involvement is a good thing. It's a good thing for us because it makes us confident when things are new, but it's also, I would think, a good thing for community practitioners because it means that you definitely feel like you're supported. There's a very clear pathway about how patients can get seen very quickly. So you're not constantly picking up the phone, which just adds other jobs for you to do in the day. And, I think a model that functions like that could be good. In terms of CPD, at the women's, there were information evenings on a regular basis that GPs had to attend. I think providing antenatal care, a lot of GPs that aren't GP obstetricians are already doing it. I certainly have some that I do share care privately with. Very occasionally, but do have that aren't GP obstetricians, and that's all about travel. But I do think, the low risk women having GP share care, just an interest is probably enough. It's not terribly complex. An interest and an insight into when I need to ask for help. So I don't think it needs to be some enormous thing. Am I being too flippant, Jyoti?
No, I don't think it needs to be an enormous thing. I think, if we've had, like an education sort of, even where we just run through some of the, really key things to, for referral, that need to be referred back in, that someone's maybe just attended at the start of the, whatever that we've decided we're going to do it, and then maybe it's a yearly or 2 yearly thing, that we just get ticked off. I don't think it needs to be a massive thing. And I think the other thing that is going to help that is if we make sure that we, really move to this pathway of seeing women early so that they are triaged appropriately for their care. Obviously, things are going to change along the way as with Cheryl's lady, the problems sort of, multiplied, and, that changes the landscape of what you're looking at. But if we can get that right at the start, that's going to make this whole process easier as well. You're going to get the right women that you're looking after. You're not trying to battle through and look after something that's a bit complex or, potentially missing things because you just weren't aware of it. Because, as I said, I feel like it is getting more complex, particularly with some of the preventative sort of care stuff that we're looking at. And if we get that right at the start, I think that's going to make that pathway much easier as well.
And I feel like that's happening. I was part of a case review for a case in Maitland, and they are doing that model where they seem to, at least for this person's case, they were seen early, and the plan was absolutely laid out by an obstetrician at 14 weeks. That was then to go back to a midwifery model, but that whole point of that early consultation and everything being very clear just makes it very easy, and in some ways is CPD in and of itself, because if people are paying attention to that and seeing what we're asking for at that initial appointment, that is educational. But I think an interest is the biggest thing. And also, if that were to happen, I would be keen to have senior GP obstetricians actually involved in the rollout of that, because I think you give perspective to other GPs that I, as a specialist, don't have on at the coalface kind of issues that I wouldn't consider an issue, but you might. And so I think you guys being involved is critically important. I think that would be really useful.
Andy or Cheryl, any comments around that? I saw you nodding, Andy, that it sounds like there is that model in Newcastle.
Yeah. For me, it's really simple. It's part of general practice, antenatal care, pregnancy care. I think for GPs with an interest, they will exhibit self-directed learning as part of their CPD, become used to providing care. It's underpinned by support from the local service, building relationships so you know who to talk to, when to talk to them. We've got the community health pathways in place that provide good guidance on clinical care as well as referral pathways. And I think echoing Jyoti's and Blake's thoughts, the way antenatal care is changing and how, Hunter New England is a leader in that space, I think provides women with the assurity and their care providers with the assurity that the preventative care strategies mean that you can embark on a model and your likelihood of having to cross over into other risk models is much less. So you get continuity of care with a known care provider, whether that be an obstetrician, midwife, midwifery good practice, or a GP. And I think if we promote that and give women that choice, we'll have a pretty outstanding maternity or pregnancy care services across our district. Thanks.
Thank you. Cheryl, any final thoughts?
So one of the other things that I'd love to see is the information that we get back from each of those visits is invaluable. So, when someone goes to see, for example, Jyoti, we get a scan result back and then a little write-up of what the plan is with that particular person and whether they're going to return to our care or whether they're going to continue to see the high-risk clinic. So often that information comes through people writing on the yellow card, so that can be the conduit of information going backwards and forwards between people. We send referrals in, but when we get something back, if it's on the yellow card, that's immensely helpful to know what was said. Sometimes I find, though, that when people go to see the high-risk clinics, we don't actually get any written feedback at all. And sometimes when they birth away, as this lady did, no paperwork at all came back from her birth to inform me as to what had happened. Thankfully, she was a very switched on, intelligent young lady and was able to explain to me what she was told with, I think, a pretty good degree of accuracy. But not all of our ladies are able to explain what was said, what was done, what needs to be done, what the plan is. And so I'd like to see what your thoughts are on ways that we can make sure that information goes backwards and forwards between us in our high-risk clinics, where people are seeing us and seeing high risk and then coming back to us in between. What are your thoughts on how we can make that work even better?
Hunter New England is going to be the first health district to roll out the single digital patient record. Dare I suggest that is going to solve all our problems?
You'd love to think so, Michelle.
6 months ago.
I seriously hope so.
In the meantime,
I think visibility of information is key. I'm not sure of the integration between single digital patient record and primary care. That's one piece I'm not sure of. I think we have an opportunity in the single digital patient record to improve our communication out of New South Wales Health into primary care. Not sure exactly what that looks like. I'm aware of patient-facing and primary care-facing pieces of the single digital patient record, which may give you read-only access, Cheryl, but again, not sure of the exact scope. I'm not sure the yellow card is obsolete just yet, but I think we may need to think about how we move to a system where we're all digitally connected, so that we don't have those concerns. And March 26th is going to come very fast, I'm sure.
Am I able to ask a question? I'm assuming, does everyone have access to CAP?
Not in general practice.
Not readily in general practice, no. Most GPs would not have access to CAP.
What about the GP obstetricians, though?
We do have some access, but it takes about 15 minutes to punch through all the layers and get in. And so there's your appointment gone. So to expect to do that for every person that comes back from another clinic, that would be really difficult to navigate, which is why the yellow card can also be very helpful. And also some of our ladies travel across the border. And so some go to Queensland. And so even if it's on CAP, they're going to Queensland for some of their care, with us for some of their care. Most of our ladies stay in this area, but some do use Toowoomba as their birthing centre, and we're doing shared care with Toowoomba quite frequently because they are a fairly big service and very close relatively compared to John Hunter, say. So we do have a lot of ladies that we share care, and we use the yellow card as our information conduit to make sure that we're updating what's happening and they can send us information so we know what we're meant to be doing in each of the visits.
I have on occasion sort of printed our e-maternity as well for women to take, because, you know, obviously, I try and write in the yellow card too, because I think that's obviously the easiest sort of form of communication. Yes. But that's, you know, it must be the GP's biggest bugbear of not receiving not receiving a discharge referral. Oh, sorry, I think I lost you there. Not receiving a discharge referral, and it's something that I hammer into the medical students. I hammer into the register because I think it's terrible, that lack of communication. I think it's, you know.
I certainly. I don't expect anyone to log into CAP as a routine thing, because I do that remotely more frequently than I would like, and I know exactly how painful it is. I suppose. And I should offer an apology, because certainly in my clinic, because I'm probably slower than Jyoti, or just a disorganized male, although I hope I'm not. But I often I'm not getting to the reporting of those scans until after the clinic, because things run, and I rely really heavily on the scan report to communicate. So that's something I need to come up with a system for my specific clinic, because I do think that report. I know what you're saying about the yellow card, and I agree completely, but, you know, for a high-risk patient, there's really not enough space to write anything terribly meaningful on that. And I certainly, from my end, have experienced the same issues from Don Hunter when I've sent private patients to MFM, and it's 2 weeks later before I get a letter in the post. So I do think perhaps that's a good thing to take away, and I'll certainly reflect on how I can try to make sure that those reports are getting to you, because I do acknowledge that is a problem. On occasion, when I know they're seeing Dr. Parsons, for example, regularly, I try very hard to get it printed and given to the patient. But like I said, often it's the end of the clinic. So we need to come up with a system for that. So thank you for that feedback, I think.
Sounds like we need to sign you up as a SDPR super user, Blake, to start
Super and Blake are not two words that go together very often, Andy, but thank you. I appreciate it.
Put your name down anyway.
I did have a comment that's non-systems, and I think they birthed her too early. Does anyone have a comment on that? 38 plus week Caesar for low dose GDM and mild cholestasis?
Yes, but I think without having access to all of the John Hunter decision making, it's difficult to make a comment. But yes, you know, we promote the philosophy of you know, aiming towards 39 weeks, you know, unless there's specific medical indications. And I haven't looked at the medical record to be able to provide any other comment than yes, we should be aiming for 39 weeks, as you say, Blake.
With that, I think we've run out of time. So thank you, Cheryl, for presenting the case. Very interesting and you know, probably not uncommon case. Jyoti, Andrew and Blake, really appreciate your comments and thoughts, and particularly your open door policy. I think that it's great to know that that we've got you in the region supporting GP obstetrics. And I think certainly for the GPs that I've been speaking with recently, I think that conversation around shared antenatal care with regular GPs is one that we'd love to progress fairly quickly. So stay tuned, and we'll have a further conversation around that. So thank you to all of you, and I might hand back to Sandra and Sandy.
Yes, thank you, Michelle, and I want to echo those thanks. Cheryl, thank you for taking the time to prepare those slides and to prepare the case, and Jyoti, Blake and Andy for giving up your evenings and your expertise and your wisdom to share with the group. And Michelle, massive thank you to you for facilitating with everything that's happening in your week this week too. So thank you, everybody. And I know that this will probably be a really good resource in the PHN Education Library for other GPs to have a listen to.
Absolutely. Thank you so much, everybody. It's been an absolute pleasure to have you all on. I really like this format, this case-based discussion format. I think it's really informative and valuable. So I'm really looking forward to being able to post this up on our library for other GPs to watch and be part of. So thank you.
Pleasure.
All right. Good evening, everybody. Have a really great rest of your evening.
Bye.
Bye.